Hello and welcome to the CNS Pharmacology Masterclass. Here we will talk about all the medications that work on the central nervous system, and we will start with the opioids. So this lecture is going to be about the opioid pharmacology, and here we will talk about a lot of topics about the opioids. So if you would like to skip to other parts of this video, you can use the video chapters in the video description if you would like so. For the people who don't know me, my name is Mustafa. I'm a medical doctor and I started creating lectures on YouTube since 2018, and I mainly make videos about the pharmacology and orthopedics. If you would like to support this video, you can by liking the video, and if you want to support more, you can by subscribing, or you can by subscribing to the Patreon, link provided in the description of this video. So the opioids are classified as analgesics in pharmacology, and before we start learning about opioids, we have to know the classification of analgesics in general, just to have an idea about what other analgesics are used in medicine. So generally speaking, we have four categories of analgesics. We have the opioids, which are the discussion of this lecture, and we have the NSAIDs, and then the third group is analgesics, antibiotic drugs like the paracetamol, dipyron, and the nifopam, and the fourth group is non-analgesic drugs that work as analgesics for some conditions. For example, the carbamazepine, which is anti-epileptic drug that is used for trigeminal neuralgia, and the duloxetine, which is antidepressant drug that is used for diabetic neuropathy. And again, here we will focus only on the opioid analgesics. So what we really mean by opioids? So they are drugs that relieve or decrease the pain sensation. They are analgesic drugs. They also lead to other effects like sedation, euphoria, decreased GIT peristalsis, and physical dependence. And they may lead to respiratory depression, which is very dangerous, and they are classified as analgesic drugs like we mentioned before. Now let's talk about the opioid terminology. So the term opioid is derived from opium, which is a plant name, and that is the plant. It looks like that, and that's what the natural and the semi-synthetic opioids are derived from, this material that comes out of the plant. So the term opioids refers to all drugs that work at the opioid receptors. They include the natural, the semi-synthetic, and the synthetic drugs. Previously, the opioids term was used for the semi-synthetic and synthetic opioids only, but nowadays it's used for all of these, the natural, the semi-synthetic, and the synthetic. The opiates is another term that refers to the drugs that are isolated from the opium plant. They include the morphine, the codeine, and the papaverine, and those all are natural. They derived from this plant, as we mentioned. Now, inside our bodies, we have the endogenous peptides with opioid-like activity in the human body. That's why we have the opioid receptors, because we already have those peptides that work on the opioid receptors in our body, and those include the endorphins, the enkephalins, and the dynorphins. We have the term that is called narcotics. This term is used for drugs that produce narcosis, which is drowsiness or stupor, but not complete loss of consciousness. Those include many families of drugs, including the opioids, and this term is a legal term more than a medical term. So it is used legally more. Now let's talk about the opioid mechanism of action. The opioids work on the opioid receptor, as we mentioned, which are three major receptors, the mu, the delta, and the kappa. And each of these receptors has subtypes. The mu has mu1 and mu2. The delta has delta 1 and delta 2. The kappa has the kappa 1 and kappa 2 and kappa 3. And there is many subtypes that are not discovered yet. And all of these receptors are G protein coupled receptors type. And these receptors are located everywhere in the body, including the brain, the spinal cord, especially the dorsal horn of the spinal cord, and peripheral tissues. So in the spinal cord, the opioid receptors are located here more. They are very dense in the dorsal horn of the spinal cord. And as we know, the sensory information is coming to the dorsal horn from the sensory nerves. And if we use an opioid drug, this would block the pain coming from these afferent nerves. And the opioids bind to these receptors and either work as agonists, partial agonists, or antagonists on those receptors. And opioid classification will be discussed later in this video. As we mentioned before, we have the agonist, we have the partial agonist, and we have the antagonist, we have the natural, the semi-synthetic, and the synthetic, and so on. The opioids may also differ in receptor binding affinity. For example, the morphine exhibits a greater affinity to mu than the codeine does, meaning that there is opioid drugs that bind stronger to the same receptor than the other opioids. For example, the morphine is one of the strong ones because it exhibits a higher affinity or greater affinity to mu receptors. Now let's talk about the classification of opioids. So as we mentioned before, we have the natural, we have the semi-synthetic, and we have the synthetic opioids. The natural opioids are on two families, the phenanthrines. Those are called the phenanthrines because they have the phenanthrene ring in their chemical structure, and they include the morphine, the codeine, and the thebaine. The morphine and codeine, they are used as analgesics. They bind to the opioid receptors and they work as analgesics, while the thebaine is not used in medicine. It is used to synthesize the other type of opioids like the semi-synthetic opioids. The phenanthrines are spasmogenic, they cause spasm, and they have potent CNS action. They work on the opioid receptors, as I mentioned, and they are analgesics. The other family in the natural opioids is the benzyl isoquinoline. Those include the papaverine and the noscapine and monrux in this group, but they don't work on the CNS and they are not used as analgesics. They have a spasmolytic action. The papaverine is used as a smooth muscle relaxant, and the noscapine is used as an antitussive, anti-cough medication. They have little CNS action, as I mentioned, and they are non-analgesics. Now for the semi-synthetic opioids, they include the heroin, the hydromorphone, the hydrocodone, the oxymorphone, the oxycodone, and so on. And the semi-synthetic opioids are derived from the thebaine, as I mentioned. The synthetic opioids are on three groups: the agonist, the antagonist, and the mixed agonist-antagonist. I forget to mention that the natural, the phenanthrines opioids all of them are agonist. They work as an agonist on the opioid receptors. The semi-synthetic opioids are also agonist, so those are agonist, and the phenanthrines are agonist. And here we have, in the synthetic opioids, we have agonist, we have antagonist, and we have mixed agonist-antagonist. So the agonists are the mipridine family. They include the fentanyl, the mipridine, and so on. The methadone family, and those include the methadone and other drugs. And we have the tramadol. In the antagonist, we have the naloxone and the naltrexone. Those work as antagonists on the opioid receptor, so they would cause the opposite effects of the agonist drugs. So they would not cause analgesia, so they would reverse the analgesia. The mixed agonist-antagonist, those are also called the partial agonist opioids. Those work as agonists on some receptors and work as antagonists in other receptors. So those include the nalorphine, the nalbuphine, the pentazocine, the butorphanol, and the buprenorphine. Now let's talk about the opioid receptor's pharmacologic effects, meaning when the opioid binds to the receptor, what will happen. So every receptor of those when activated lead to CNS effects, and by those I mean the mu, the kappa and delta. So it lead to central nervous system effects, lead to cardiovascular system effect, GIT effect, biliary effect, renal, uterus, endocrine, and immune effects. The CNS effects include analgesia, euphoria, sedation, respiratory depression, cough suppression, miosis, truncal rigidity, nausea and vomiting, temperature changes, sleep changes, and pruritus. And all of those effects are caused by the agonist drugs, the antagonist drugs, which cause the opposite effects. And I will explain every effect of them in the next slides. And some receptors would be better in specific results than the others, like mu receptors gives better analgesic effects than the others, and the effects above occur with agonist opioids, antagonists do the opposite as I mentioned. So let's start with analgesia. So the pain consists of sensory and emotional components, and the opioid analgesics suppress both of these components. And this is very good because they would be very good in relieving pain, and they are actually the top drug in relieving pain, especially the severe type of pain. Second comes the euphoria. So it's a pleasant sensation with decreased anxiety. The agonist opioids lead to euphoria, as I mentioned. The antagonist opioids lead to dysphoria, which is an unpleasant state with restlessness, which can be a side effect of antagonist opioids. We also have sedation. The sedation is decreased consciousness, which is drowsiness. So the patient becomes drowsy and they would have some amnesia. So they can't remember some of the situations that happened during when the drug was active in their bodies. And sometimes the patient sleep. Patient can be easily aroused in those while using opioids in comparison with sedative hypnotic drugs like the benzodiazepines. The patient might go in deep sleep. Now let's talk about the respiratory depression. This is the most important effect that you should know of opioids because it might kill the patient. All the opioids agonists lead to respiratory depression by inhibiting the respiratory center in the brainstem, and it is dose dependent, and there would be CO2 retention occurs with cerebral vasodilatation and increase in intracerebral pressure. So when the patient administer a high dose of opioid, this would lead to the patient having a slow respiratory rate, and this would lead to CO2 retention, and the CO2 would lead to cerebral vasodilatation, and this would ultimately increase the intracerebral pressure. And respiratory depression is worse in patients with asthma, COPD, and head trauma. So that's why the opioids are contraindicated in these patients. The opioids are also cough suppressant. They work to suppress the cough. The codeine is used in treatment of pathologic cough, and this would lead to accumulation of secretions and atelectasis, meaning this might lead to accumulation of secretions and the lung airway might be blocked, which lead to atelectasis. And the cough suppression is what most opioids initially used for. They used to suppress cough, but nowadays they are not used for that because there is better alternatives with less side effects. Now let's talk about the miosis. The miosis is constriction of the pupils occur with all opioid agonists due to vagal stimulation. Because remember, the miosis comes with the parasympathetic system stimulation, while the mydriasis would come with the sympathetic system stimulation. And miosis is when the pupil size is less than 2 millimeters. This is an example for that. And it is mediated by parasympathetic pathway, as we mentioned, which can be blocked by the atropine. And severe miosis is indicative of toxic doses, meaning the patient with toxic dose of opioid, they would present to you with a pinpoint pupil, meaning they have severe constriction of their pupils due to the toxic dose of opioid they took. So next time you have a patient comes to the emergency department, make sure to look well to their eyes, looking for the pinpoint pupil sign. And miosis is a fixed feature in all addicts. We also have truncal rigidity as an effect to some opioids. So some opioids increase the tone in the trunk muscles, and it has supraspinal mechanism, and it interferes with ventilation, make it hard to breathe, and it occurs especially with fentanyl, sufentanil, alfentanil, and remifentanil. So it occurs with all the fentanyls. Another effect is the nausea and vomiting. This is one of the common ones, and it's present as a major problem in opioid use, and it occurs due to activation of chemoreceptor trigger zone in the brain, and it leads to nausea and vomiting. The temperature is another effect because the endogenous opioids, peptides, which are the endorphins and the enkephalins, partially regulate body temperature through their action on the mu receptors, and the exogenous opioids would also affect the body temperature too, because they work on the same receptor as the endogenous ones. For example, the morphine produces hyperthermia. The pruritus is another effect, and it is very annoying in opioid use because most opioids like morphine lead to pruritus, flushing of the skin, and itching, and the mechanism of pruritus is through peripheral release of histamine, because when using the opioid agonist, this would lead to histamine release and central activation of proprioceptive neural circuits, which lead to pruritus. We also have sleep changes, and the opioids decrease stage 3 and stage 4 of the sleep by unclear mechanisms, and this leads to sleep disorders and fatigue-independent people. Now we finished the CNS effects. Now let's talk about the cardiovascular system effects. So most opioids lead to bradycardia, which is due to the vagal stimulation that we talked about before, except mepridine, which has antimuscarinic action, which results in tachycardia. So all agonist opioids lead to bradycardia, except for the mepridine, which lead to tachycardia. Hypotension may occur with opioid use if there is some pathology in the CVS system. So if it is only bradycardia, then hypotension might not occur, but it is certainly will occur if there is some pathology in the cardiovascular system like heart failure or something like that. Let's move to the GI tract effects. So the opioid receptors exist in high density in the GIT, and when activation lead to decreased stomach motility and increase the tone. And this lead to increase the HCl secretion, the hydrochloric acid secretion in the stomach, and small intestine tone increases with periodic spasms, and the amplitude of the non-propulsive contractions is decreased. In the large intestine, the propulsive peristaltic waves markedly decreased, and the tone is increased, which lead to delayed passage of feces and allows more absorption of water, which ultimately lead to constipation. Constipation is another major problem in opioid use for cancer pain. And this can be advantageous in diarrhea treatment. There is opioids that are modified to not cross the blood-brain barrier, so they work only on the GIT to treat diarrhea, like loperamide. We also have some effects on the biliary tract. The opioids lead to contraction of the biliary smooth muscles, which lead to biliary colic, and contraction of the sphincter of Oddi, which lead to reflux of biliary and pancreatic secretions. So the opioids would contract the biliary smooth muscle, and it would contract the sphincter of Oddi. This lead to the biliary secretions would be trapped inside the biliary tract, which would lead to pain sometimes and if the patient has another pathology in the biliary, this might lead to acute cholecystitis. Let's talk about the renal effects. So the neuroreceptors activation in the kidney and the central nervous system have antidiuretic effects and lead to decreased renal function. The urethral and the bladder tone are increased, and sphincter tones also increased, which may lead to urinary retention, especially in the post-operative patients. And urethral colic could become worse when using the opioid as a pain control. So the activation of chemoreceptors in the kidney and CNS will lead to antidiuretic effect, meaning they would decrease the renal function, so there is less water being excreted through urine. And also the opioids would work on the chemoreceptors in the ureter and bladder, which increase the bladder and ureter tones, which also trap the urine and might lead to urinary retention. And also the urethral colic, which is resulted in a stone passing through the ureter, might be worse with the opioids, except for the mepridine, which is also the bethidine, that has anti-muscarinic effect that might work on the ureter and lead to dilatation of the ureter, which is better than the other opioids. There is also effect on the uterus. If a pregnant woman took opioids, this would lead to decrease the uterine contractions, which lead to prolongation of labor. And there is also endocrine effects because the opioids stimulate the release of ADH, which is the antidiuretic hormone, which lead to increase the water retention, and they also increase the secretion of prolactin, somatotropin, and inhibit luteinizing hormone secretion, and this lead to decreased testosterone in men, which subsequently decrease libido, energy, and mood. And women can experience dysmenorrhea and amenorrhea due to these changes. Regarding the immune system, the natural killer cells and the lymphocyte proliferation is inhibited by opioids, and this allows infection to become worse and allows tumor to progress more in cancer patients, and the mechanisms are complicated. Now let's talk about the opioid therapeutic uses. And as we classify the opioid as analgesics, that is why the analgesia is the #1 use for opioids. And they are used for severe pain because they are the best analgesics that we have right now. They are also used for acute pulmonary edema from heart failure, especially the morphine, because it reduces anxiety, it reduces cardiac preload and afterload, and it reduces the pain. And they also work on diarrhea, like loperamide, as we mentioned, and they used to be used for cough, but now they are not because of the better alternatives that is available right now for cough suppression. And they are used for shivering, especially mipridine, and they are used for anesthesia, before anesthesia as sedative and anxiolytic, and during anesthesia also used as a part of the anesthesia to decrease the sympathetic system effects. And they are also used in regional anesthesia. Now we move to the adverse effects of the opioids. We have the respiratory depression, the nausea and vomiting, and the constipation, and we talked about all of those before. But we also have the tolerance and dependence, and that's what we will discuss now. So now let's talk about the opioid tolerance. Repeated doses of opioids have a diminishing analgesic effect, and that's what we call tolerance, meaning with time the same dose produce less effect due to neuroadaptation and receptor upregulation. So the neurons would adapt to the opioids, and the opioid receptor would increase in number, which make the same dose would not produce the same effect, meaning the patient need to increase the dose to get the same effect. And every opioid drug leads to tolerance, but in different periods of time. Examples are the morphine takes days for the patient to develop tolerance to morphine, while the remifentanil in hours. The patient develop tolerance to the remifentanil in hours. The tolerance develops to most of the effects of the opioids. Example, the tolerance developed to analgesia, sedation, respiratory depression of opioid agonist. It also develops to the antidiuretic, nausea and vomiting, and constipation effects. It is possible to produce the respiratory depression in 60 milligrams of morphine dose in non-tolerant person. So if we take a person that never used the morphine in their life and we give them 60 milligrams, this might produce respiratory depression for them, while respiratory depression may not develop after administration of 2000 milligrams of morphine in 3 hours in tolerant person. So if a patient has cancer and they use morphine and they are tolerant to the medication, if we give them 2000 milligrams in 3 hours, they might not develop respiratory depression in that period. And tolerance is difficult to predict. It depends on a lot of factors. Example, the effect of the drug type, the time, and the individual genetics. And the tolerance also develops to partial agonist drugs, not just to the agonist opioids, but also to the partial agonist opioids. The tolerance also develops. And the cross-tolerance is common. Example, patient tolerant to morphine would have less effect in analgesia to other opioids, but it is still, when changing the opioid, there would be much better effect at the same equivalent dose. Opioid rotation, meaning changing the opioid drug used every period of time to prevent tolerance, is used in patients with cancer and chronic pain. Changing the opioid would have a much better analgesia, as we mentioned, at a lower equivalent dose. Now let's talk about the opioid dependence. We have the physical dependence and we have the psychological dependence. The physical dependence is failure of continuing administration of opioid drug, resulting withdrawal syndrome, because the body has physiologically adapted to the opioid drug. So when the patient takes the opioid, with time their bodies would physiologically adapt to the drug that they have to continue to take it. If they stop for any problem or any reason whatsoever, this leads to withdrawal syndrome. Now, what we mean by withdrawal syndrome? Well, withdrawal syndrome presents as rhinorrhea, lacrimation, chills, hyperventilation, anxiety, hyperthermia, mydriasis, muscular aches, and vomiting and hostility. And all of those symptoms will be present in a patient with withdrawal syndrome. And severity of these symptoms depend on the degree of the physical dependence to the drug the patient have. Examples, the morphine withdrawal signs start after 6 hours of the last dose, because the half-life of morphine is around 6 hours, and the peak withdrawal signs are seen at 48 hours and gradually subsides within 5 days. The mimipridine withdrawal syndrome subsides within 1 day, while the methadone withdrawal syndrome takes 2 weeks to subside. So every drug have a different withdrawal syndrome period. Administration of naloxone to opioid dependent person. Remember, the naloxone is antagonist drug. When you administer the naloxone to the patient dependent on an agonist opioid, the person can give explosive type of withdrawal syndrome, which can occur within 3 minutes of administration. So if you give naloxone to an opioid dependent person, this person might become dangerous. They might kill themselves or kill somebody else. So you take the important measures if your patient having respiratory depression when you give them naloxone. Administration of mixed agonist-antagonist also precipitates withdrawal syndrome, but it is lesser in severity when administering a full antagonist. So when you administer a partial agonist, it would also precipitate a withdrawal syndrome in a patient that are dependent on an opioid agonist. But the symptoms are less than when you using a full antagonist like naloxone. So now, after we talked about the physical dependence, now let's talk about the psychological dependence, which is also known as the opioid addiction. The opioid addiction is the more famous name for the psychological dependence of opioid, and it is chronic disease of the brain, affecting reward, motivation, and memory. This leads to dysfunction in these circuits, which lead to biologic, psychological, and social manifestations. And opioid addiction is characterized by impairment in behavioral control, craving, diminished recognition of problems, and dysfunctional emotional responses. And finally, let's talk about the opioid contraindications. So, first one being giving a partial agonist to a patient on full agonist is contraindicated because this leads to diminishing analgesia and might lead to withdrawal syndrome, as we mentioned earlier. Example would be giving bentazocine to a patient on morphine, which might lead to withdrawal syndrome. And opioids are contraindicated in use in patients with head injury because this leads to increase the intracerebral pressure and would aggravate the injury to the patient. And they are also contraindicated in pregnancy. The fetus become physically dependent on opioids and manifest withdrawal symptoms in early postpartum period, and symptoms including irritability, crying, diarrhea, and even seizures. And opioids are contraindicated in use in patients with impaired pulmonary function because, remember, they lead to histamine release and bronchoconstriction, and also lead to vagal stimulation and more bronchoconstriction. And they are contraindicated in use in patients with impaired hepatic or renal functions because opioids metabolized by the liver, and if the liver is impaired, then their half-lives are prolonged. And contraindicated in use in patients with endocrine disease. For example, the patients with Addison disease and hypothyroidism mostly have exaggerated responses to the opioids. And with that, we reach the end of this video. Please like this video and comment if you have any question. I will try my best to answer all the questions posted in the comments.